Medical Service Company is excited to offer an additional layer of support to our dedicated providers, introducing the Sales Support Representative Team, specifically designed to assist those caring for diabetic, sleep, and respiratory patients. This team collaborates with our existing territory managers to provide an unparalleled level of service and support to the DME industry. These experts will work closely with you and your staff to ensure the best experience possible when partnering with MSC. Over 400 providers from Indiana, Michigan, New York, Ohio, and Wisconsin are already benefiting from this new team. Our goal is to make prescribing home medical equipment the easiest part of caring for your patients. The Sales Support Representative Team offers a range of services, including an additional point of contact, order tracking, issue resolution, weekly status reports, follow-up calls after equipment delivery, and more. This approach ensures faster patient care and enhances the overall experience, leading to better compliance with at-home therapies. A smoother experience means happier and healthier patients who can stay comfortably at home. If you're interested in joining this exciting program or would like information, please contact your local territory manager or visit www.medicalserviceco.com. We look forward to delivering best-in-class care to you and your patients.
Our next lecture will be presented by Dr. Colleen Lance and is titled Leveraging AI in Sleep Medicine. Dr. Lance is a sleep medicine physician with over 22 years in the field. She's held roles as the medical director for sleep laboratories at institutions including the Memorial Hermann Hospital System, University Hospitals, and the Cleveland Clinic. She's also served as medical director of PAP therapies at Cleveland Clinic Home Care. She is currently the Chief Medical Officer of React Health. Her service has included work on the Payer Policy Review Committee and the Political Action Committee with the American Academy of Sleep Medicine, as well as being the former president of the Texas Society of Sleep Professionals. We would like to thank Dr. Lance for her participation in today's forum. And at the end of the lecture, Dr. Lance will address questions you've submitted related to the presentation. You can send in your questions anytime during the lecture by clicking the Engage tab above the presentation screen. Don't forget to complete the survey afterward as well. We hope you enjoy this lecture.
Good morning, and thank you for the invitation for presenting today. I'm so happy to join you. Today, we're going to talk about a topic, AI in PAP therapy management. And as an example of the utilization of AI, I have here a picture created from OpenAI. When I'm creating lectures, I'm usually trying to find a way to find images, being very careful of copyright. And what I've found is you can use AI to start creating images. You give it some training, tell it what you're looking for. And the training I gave the AI here was give me an example of what therapy in the sleep lab utilizing CPAP might look like. And this is what DALL-E, the computer software, came up with in OpenAI as an example to open up our discussion. So today we're going to cover some areas, some of which you're going to be very familiar with. We're going to talk about the challenges that are facing us in the adherence arena for PAP therapy. That is not going to be a surprise to anyone, but that's just to frame the rest of the discussion. Then we're going to look at the intersection of how AI and the management of sleep therapy can be utilized to approach a patient population. We're also going to look at ways that we can operationalize AI to help make our everyday lives, whether we're working in a sleep laboratory or a DME or a physician's office, on what we can do to make our lives easier. And then also, we will explore the motivations to adopt AI, because we can have all these fabulous tools, but unless we're willing to make that change, and change is difficult, we're going to look at ways to motivate to make that move. So let's begin our discussion a little bit with what we know about adherence for CPAP. Now, there is no surprise out there that we have struggled with the use of CPAP and getting our patients comfortable and adherent. What we found was after CMS started to utilize their guidelines of 70% of the night for 4 hours at night or more, that you see a bump in adherence up to 72% during the first 90 days. Now, one might look at that and say, oh, wow, that's great. We've really made a change. However, there's a very rapid decline that happens over time. And overall, we're looking at non-adherence of 30 to 40% in the United States. And regardless of what bells and whistles we've put on CPAP or on the mask interface, we've just struggled with being able to move that needle. And if we compare and look at populations, like say you take a non-sleepy population, they don't have much in the way of cardiovascular disease burden, and you've got them on CPAP, what happens with that patient population? Well, less than 50% of them are adherent long-term, and they're averaging about 3 hours a night. And this is not just in the United States. You might wonder what happens in other countries. France being an example, where Dr. Jean-Louis Pepin has done some studies where they've got a very controlled patient population in Europe under a one-payer system. Have they been able to move the needle? And actually, they struggle with termination rates at years 1, 2, and 3, up to the point where almost half the patient population has actually terminated PAP use. There's absolutely no surprise as to the most common reasons that people struggle with the use of PAP therapy. The industry keeps looking for ways to make the interface more comfortable. People don't tolerate the pressure. Environmental factors, socioeconomic, being able to afford and access healthcare is a continuing issue. But what I've found over time, and having been patient-facing for 34 years, and more than 20 of those being in sleep medicine, that the biggest issue surrounds motivation and behavioral changes. Because if you can get at the motivation and target the behavior, then you can start moving the needle regardless of the other things that are going on. Now, at the end of the day, we all want very similar things. No one comes into work and says, I really want to do a bad job today and make patients as angry as possible and get them to quit. No, we want to provide wonderful care, but we also want to do it in a way that doesn't drive us nuts. We don't want to spend all of our day in an electronic health record or trying to parse through every single patient, doing very menial tasks. And we want to be able to go home at the end of the day after a fair day of work and fair pay. And I'm a little bit of a sci-fi freak, so I was recently at Comic-Con Museum in San Diego and took a few shots of the Popnology exhibit where they were showing AI. And Douglas Adams, author of Hitchhiker's Guide to the Galaxy, a quote from him is that at the end of the day, what we really want is just stuff that works for us. In essence, we want to make our lives easier and have the technology to do so. Now, to frame where we are today in healthcare and specifically within sleep medicine, I want to frame this around the time of the pandemic in 2020. Coming up on the pandemic, we already knew that we were struggling with healthcare costs and problems with equity. We had shortages in providers that only got worse after the pandemic. We've managed to make the process of getting healthcare, getting PAP therapy, and becoming adherent so complex that just the process alone can be daunting, almost too daunting for a lot of patients. And then you throw burnout of healthcare providers in there, and that only makes the situation worse. Then you put in what happened in 2020, and I like to call this the crucible. You had the pandemic, you had a recall for an FDA Class 1 recall that I do not know anyone that was not affected by this. You had supply chain issues. connectivity issues. And then to top it all off, we start having shortages with providers, physicians, mid-levels, technologists, respiratory therapists across the board. So all of this is working together to make life much more complex and a very difficult scenario trying to work with patients and get them adherent on PAP therapy. A word on sleep technologist shortages. Now, the AMA's got really good data on the projections between now and 2030 on what physician shortages are going to be, and that's enough to make you want to pull your hair out. Specifically with sleep technologists, there's not a lot of data yet, but I do not know any sleep lab that is not struggling to fill positions, to get patients into beds and to get them studied. And then the BRPT, although back in 2009, there was already a perception that there were shortages. If we were to repeat this and get some hard data now, I think the numbers would have jumped greatly. So at the end of the day, we are having an increased workload with much fewer people to provide care. And it very much is like this mechanization that we saw around the 1900s. This is Charlie Chaplin on the right-hand side. And you feel like you're caught in a factory and you're just churning out patient after patient. And at the end of the day, we're still not moving the needle. But one might say we're standing at this point where we've got all this great technology, we've got great discoveries. Why haven't we been able to move the needle with our patients? So if you stop and just look at where we are in science of sleep medicine now, it seems like it's a really great time to be practicing. We have a much better understanding of sleep apnea. I mean, it used to be back in 1970s, 1980s, every patient was approached the same way. Everyone was plopped on a CPAP. There were certain expectations. And then if you didn't meet those expectations, we would just double down on the same therapy. But now, using phenotypes and endotypes, we're able to understand the physiology much better and to determine what patients are appropriate for PAP therapy. Some might be more appropriate for surgery, some for oral appliance. The vast majority of my patients in practice, we use multimodality therapy. There wasn't just one form of therapy for each patient. It was highly personalized. We've got wonderful ways of evaluating treatment, and that's what measuring PAP adherence is about. We are looking for efficacy and adherence. Are the patients able to use it, and is it working for them? So it seems like it would be the golden age, but yet we still struggle. And what the future is going to look like is very much a value-based care model where reimbursement is going to be driven by showing that you've improved the state that a patient population is in. So from the doctor position, which is what I'm used to, we're so used to looking at just one patient at a time as they are in front of us to improve their adherence. What we historically have not been very good at is stepping back and looking at our entire population and saying, when I make this change in behavior and work on this with this specific tool, I'm able to provide higher value to my patients. Now, that's going to be how we're reimbursed in the future. DMEs seem to be understanding this sooner than the physician population, but we're going to see this across the board. So another moment from Comic-Con Museum, and I hope a few people in the audience recognize this. One of my favorite movies, 2001, from Arthur C. Clarke's books. And his quote is, "People who say that we will never develop computer intelligence merely prove that some biological systems don't have much intelligence." And this is how 9000, the AI that was in the spaceship in the movie 2001 that was made, let's see, this prediction was made back in 1964, so late 60s, early 70s. So the concept is by no means a new one. So let's pause here for a moment and put some framework around what we mean by artificial intelligence in this day and age. So we can look back in time and actually see the beginnings of artificial intelligence as far back as the 1950s. And so we'll call that era AI 1.0. And this is when we're dealing with probabilistic models. And what we did was we gave if-then rules or decision trees where we would tell a computer, if you see, or a program, if you see this situation or have this situation or this question, follow this rules. If this happens, then what? And an example of this was IBM's Deep Blue, when it took on the world champion in chess and won. And that was one of these very heuristic models at the time. But those models tended to have problems mainly due to human logic errors and bias and dealing with real world situations. So fast forward to the 2010s, this is when we started seeing AI 2.0, or deep learning models. This is when you could train and on a task-specific situation where a computer model could start predicting situations. And an example of this is when we started seeing photo searching. If you look at things like Google and Facebook and LinkedIn, and voice recognition and being able to do facial recognition and voice recognition as well. And we started to be able to use in healthcare breast cancer and lung cancer screenings to start identifying and predicting in certain patient populations. Now, one of the situations you run into with deep learning is you can sometimes get into catastrophic forgetting. So that is when you're giving real-time data and then and the model is going along in a sequence one after another. But what happens is you get this big long sequence and the computer model forgets where it started from. So it's catastrophic forgetting. So that's like me deciding I want to go in the kitchen and get something out of the refrigerator. But in the meantime, I had to go pick up the laundry, chase after a kid, go out and grab the mail. The doorbell rang, then the phone rang, and then I opened the refrigerator door and I'm like, I have no idea why I'm standing in front of this refrigerator. So that's an example of what can sometimes happen with the deep learning models. Now, AI 3.0, which is where we are now, are some foundation models where the AI is able to generate new context, like the example I showed on the picture in the first slide, where I gave it some parameters and asked it to create something for me or to perform a task, not necessarily with every parameter plugged in for it. This is in real life. When you ask a computer this, an example or a computer program, you might say, explain the difference between a cat and a dog. In healthcare, this is where we're starting to get specific chatbots. So, or if you look at PubMed GPT or Chat GPT. So these are the GPT models that we're seeing commonly now. Some of the problems we have with this now is something called hallucination, where you ask the AI a question and it will give you what you asked for. And it seems like a very plausible answer, but it's not really true. An example of that is here. Is it a Chihuahua or a muffin? So you could make an argument for each and every one of these pictures that it could be a Chihuahua or it could be a muffin, but it's not really true. So while the framework and what the AI models are able to do now is incredibly impressive, but at the same time, it doesn't replace what we're able to do, and it's not always 100% accurate. Because I bet some of these are yummier than others, and not all of these are muffins. So, what about studies, specifically with the areas we deal with every day? the most important being adherence for our population. The next several slides are studies that were done by Enzo Data, who they arguably have the strongest body of work in this area to date. And so here, they were taking very large numbers of patients. This particular study was more than 34,000 patients and their data and adherence. And the first question they wanted to ask, and that's what this study explains, is, can a deep learning model predict adherence? And is it at least as reliable as what we're currently doing? Now, this is called a receiver operating curve or a ROC analysis. Now, if you're not doing statistics all the time, what you want to do with a ROC analysis is your results, if they're significant or important, they're going to hug to the upper left-hand corner, and that means that you've done well and you've got a really good answer. And here we're looking at true positives versus false positives, and we're asking, can it at least do as well as what we normally do in predicting adherence? And we looked at 3 months, 6 months, 12 months. And if the deep learning model wasn't able to perform, your line would look like this red line here. But if it does well, it's going to hug this upper left-hand curve, which is what it does. So what they realized in this study was that the 3, 6, and 12-month mark, that the deep learning model was able to predict adherence at that 90-day CMS requirement mark. So checkbox on the very first question they asked. They were successful. The second question they asked was, can we do predictions? And if so, what type of model is the most predictive, and how early can we predict if someone's going to be adherent at the 90-day mark? And so in this particular study, they were looking at 2 different models of behavior. So model number 1 was, do you have patients that just periodically don't turn on their CPAP at all at night, versus some patients who will use the CPAP during certain portions of the night, but they still at least turn the darn thing on every night? And then the second question is, how early can we get a prediction? So how early can I tell if someone is going to make it or not going to make it to that 90-day mark? So what they found here was that looking at model number 1 was most predictive from a behavior standpoint. If people have nights where they don't even bother to turn it on, those are the patients that are really going to struggle with being adherent at that 90-day mark, more so than the patients that are at least turning it on and trying every night. Now, the second part of this study was, how early can we predict? So the machine learning models are here in this second column. And what they found is linear regression models, what you're trying to do is, if you start seeing clustering of the points and it's enough to be able to turn it into a straight line going through most of the points, then that's a good answer. So as early as day 7, they could start predicting if any one particular patient was going to make it to the adherence at the 90-day mark. So they got a positive result there as well. So then moving on to the next group, where they were looking at 37,000 patients at Kaiser, and they wanted to see at 90 days and 360 days, what happened with the prediction models and what gave you the most information to be able to predict the adherence. So they looked at several different populations, if you will. And this is one of those ROC analysis, again, where you want curves that are up towards the upper left for meaning a really good result. And what they used was, you have usage, you could look at leak, you could look at certain data points off their diagnostic, either polysomnography or home sleep apnea test, or you could use combinations of them. So the blue line is using usage and leak. The green line is usage plus diagnostic information, or if you combined all three, that's yellow. What they found is if you just looked at somebody's sleep study, that didn't really tell you if they were going to use it or not. You did a little bit better if you looked at someone's leak alone, if they were going to be adherent or not, and do that prediction. Where you were best was if you started combining information, particularly if you had usage plus something else, usage plus leak, usage plus diagnostic, and the absolute best being the three combined, and you're able to hug that upper left-hand side, which is what you want. You're not at the 360-day mark. It's not as predictive, but we're still heading towards that upper left-hand corner, so still helpful. So usage plus additional information is a win for being able to get a machine learning model that can predict how a patient is going to do. This is another visualization of that exact same study, showing that if you combine those points, that as early as 7 days, you can predict how someone is going to do. So just a slightly different visualization. And the last scientific study that I'm going to show here before we move on to the next component, and I hope everyone's still awake after looking at statistical things. The last study was a rather elegant study where they wanted to see if they trained a model and ran a regression analysis and looked at some behaviors. Could they intervene, and what would happen if you intervened early enough? Could you actually change if they were going to be adherent at that 90-day mark? So they took a group of 14,000 patients, and they took a cross-sectional group of them, of 3,600 out of that, and they looked at a total of 455 days. And what they did was they set up phenotypes of users. So by that, you had the people who were good users. So you would divvy up their adherence, the first 30 days of adherence. You would look at little 10-day chunks of adherence, and you would give them a grade, if you will. A, of course, being the best, B and C. And then you would give them a score based on what their rating combination looked like. And then you would look at their adherence data, and using that information and putting it together, again, the regression analysis, you're trying to do something where you're drawing a straight line. If you were able to put that information all together, you could start phenotyping patients out and seeing who needed and who did not need early intervention. And when they were able to identify these patients who were variable, occasional, or non-users, the ones that had more yellow and red, they could target that patient population and focus on an intervention. And at the time of resupply, then, or even earlier, then they were able to move the needle and on their adherence and get them to the 90-day mark in an improved fashion. So what we've found through the studies is, number one, that the machine learning models can do a good job in predicting adherence. Number two, they can predict if a patient's going to be adherent at the 90-day mark as early as 7 days into the mission. And then thirdly, we can combine other variables to make that prediction stronger, and particularly if we're looking at behavioral patterns as well. Okay, so we're going to pause here and think about what can AI from a practical standpoint do, because at the end of the day, and when we're sitting either in our clinic or in the DME, and we are trying to parse through an entire population of patients, it can be overwhelming, and you're trying to figure out who needs what and who's the highest priority and who needs my attention to be able to get my whole population adherent. So I'm going to give you some examples of what we're doing in conjunction with Enzo Data within React Health Connect, which is our adherence platform. So, what Enzo Data did was they came up with a series of tasks. So, think about you're doing your laundry or your chores around the house. And so you make your list of tasks and you're like, I don't want to have to do all this. I don't want to have to go out and mow the yard, get the mail. All right, maybe I'll chase after the kid, but it'd be nice to get rid of the laundry. Um, but that's what they came up with, all the different little tasks that you've got to analyze and figure out for a patient and put that into a format that would help you prioritize what your day looks like and the patients that are in the most need. I'll give you an example of one patient and what it looks like within the dashboard. So this is an overall summary view of one patient in particular, where they took AI and the task list and looked at the adherence and predictive models and what happened with the alerts that came to the providers based on that. So this first line, we're looking at usage, and this particular patient, the magic red means it wasn't that great. So during that first week, it was way less than 4 hours. We could tell right away this patient was struggling. And based on the prediction that if we could get them to start using it longer, we could get that or intervene here, then we could start looking at adherence further on by this point. And the way that was done was they gave patients a priority based on the different factors that were fed in from the task list. So this particular patient, because things look so poor right here, they were given a very high priority. And then as their predicted adherence, so they started using it more. So the prediction of how they would do at the 90-day mark started inching up. And once they got to a point where they were kind of clear sailing, their priority dropped. So what happened was you fed all these factors into the deep learning model. You're wondering, hey, what does this patient need? What is their priority? Where do they stand within the entire population of needing attention, and what do they need? And then there were tasks that were generated based on what the priority ranking was. And if you notice, all the tasks were more at the beginning when the patient needed it, and then the alerts for tasks dropped off over time. And the final one is, the task is, hey, by this particular date and time, we know your patient will be adherent. So your attention can now focus on others because this person's golden. All right. Let's look at another example. So you have a patient here who the usage is very hit and miss. Pretty much 98% of the nights are putting it on, but some nights it's up over 4. A lot of nights it's underneath 4 here with the red bars. So their predicted usage, it's like, okay, it's getting a little bit better, but it's really not getting up to that 4-hour mark that we're shooting for, and very few times that the bars actually stay green in the predicted model. So this patient is really at risk the whole time because they're not consistently getting up over 4 hours a night. So what happens with their priority ranking? They start at the very highest priority rank. It drops a little bit because they've got some nights where they get up over 4 hours a night, but overall it still stays pretty high. Drops a little bit when they had a few nights here in a row where they did well. And there were tasks generated the entire time. But there came a time where it's, you hit go or no go when it comes to looking at their 90-day adherence. And so at this point, they're not going to make it. So this final flag is no matter what you do at this point, it's a no-go for CMS adherence. So at that point, it's a hard stop. We have to hard stop, reevaluate the patient, and usually involving the provider and deciding if this is something that we need a different form of therapy or a different direction in therapy and which way we're going to go with that patient. But for your workload ceases there. So any other effort you throw into this patient really is not going to help for that particular point in getting them adherent. So the tasks cease. So what did they find at EnzoData when they started utilizing AI? They had a beta go live in March of 2023, and they started seeing a jump in adherence in their populations right away. I've got a couple of screenshots here of what it looks like on the DME side of React Health Connect when you power the adherence platform with AI through EnzoData. Now, what this is this is a list of a particular person's patient population. So on the DME side, you can look at this either as a respiratory therapist account where they're looking to see what their day is going to look like, or you may be an administrator who is looking to see what does my population for the entire DME look like. And this will rule by exception, where it filters out the patients that don't need the attention, but it creates buckets to let you know how your patient population overall is trending. So this particular one, there's 92 items that need to be worked on. 181 of the entire patient population has already met compliance. There's 6 that need to be reviewed, and 3 that compliance hasn't been met and have to be reviewed. So it allows someone to know right away what their day is going to look like and where they need to prioritize someone based on a priority ranking that is here. This is just a blown up version of this where you see the various buckets that the patient population gets placed into and a priority ranking here. So you can risk stratify your patient population. Now, the tasks are also listed off to the side, so you have an idea of, okay, why is this patient this priority? So data is missing, usage is low, large leak. So you have a bird's eye view of what you're going to need to face. And then you can parse out your day based on what you want to tackle. Like, I want to take care of all the big leaks or the people that just haven't turned the darn thing on in a few days. All right, let's pause and talk about adapting to change, because this is key both for your patients as well as us. For us, being willing to make that change and adopt habits that include AI can be difficult, just like it's difficult for your patients to be motivated and to make that change to use PAP therapy. It really takes a desire for a change and behaviors that will support that. So why is it so difficult to adapt to change? And it's the way our neurobiology is set up. So I know that when I started in my current job, for instance, I tended to be very much a Google person. But our organization works off of Microsoft and Teams. I realized I was going to have to make a change. It is painful and scary. I actually got to a point where I had to cut myself off from Google because my default is to always reach for Google. Because for me it felt easier because I knew it and I'd already done it. But I had to stop and think, long term, this is going to be better both for me and for the people that I work with, that we're all speaking the same language and doing the things the same way. So our bodies associate change with error and uncertainty. So it feels like you're doing, if it's uncertain, it must be wrong. And that creates fear, and a fear that there's going to be a negative outcome. So what happens is we start making choices that aren't logical, because it's logical to say, if I do this, my life's going to be a whole lot better, or work is going to be stronger, or I'll have better teams to work together. But it's very easy to get caught in the current thing of what you're doing. And inertia is the biggest challenge to change, just getting started and deciding that I'm going to make a change and adopt a new behavior. So Dennis Wong is a physician who's at Kaiser, and he was on several of the studies that I showed earlier. And him and I were talking about, how to adopt a change and start utilizing AI more. So he issued me a challenge on a few things. And so that's why I started utilizing the Bing Copilot. And also created some of those images that you saw, or when I run into various tasks throughout my day, trying to bake in and utilize AI in my daily tasks. And I find that it is really getting me through the day faster with improved outcomes. So it usually takes things and within the field of change management, they use beans. These are behavioral enablers, and they give you nudges to help make things positive to keep you moving along. So you identify these desired characteristics and things that are going to block you from making that change, and then to consciously choose to overcome that barrier. And examples of this, we're very used to apps using beans all the time. This is exactly what all the behavioral change apps, whether it's weight loss, changing how you react to situations, helping with psychology and how you're approaching life, it's all the same thing. You're looking at ways to affect a change that are simple, fun, engaging, and consistent with how things are from an organizational standpoint. And this can be a difficult change, particularly if, say that you put on your administrator hat. You're either running a practice or a DME, and someone says, I've got this great new fill in the blank, and you really need to try this because your life's going to be better. But how many times do we actually see the change happen? Because it's so easy to stay where we are. What is difficult is finding ways to motivate, and especially those, if anyone's here that's in leadership, finding ways to motivate the people that work with you to do something that's different, because it usually means some work and effort up front, and being able to see where you're going as an organization and what that will do for you is very helpful. So I've been in sleep long enough to have seen several things come along that make people afraid. And one of those basic fears is fill in the blank, X. X is going to take my job. I won't have a job anymore. So I've seen that a few times. Home sleep apnea testing was one of them. I remember how afraid people were of home sleep apnea testing. And there were definite changes. Those that didn't adapt and adopt to that change, we did see some laboratories close. We're seeing some consolidation. The patients aren't going away. There are still projected 54 million patients in the United States with obstructive sleep apnea, 85% of which have not been diagnosed. Our jobs are not going away. Now, being able to get a job, keep a job, a higher paying job, being able to utilize and have knowledge for the most pertinent skills is key. So it is important that we start learning how to utilize AI, both as someone who's working for an organization, or if you're a leader in an organization. We're even starting to see some regulatory things coming down the road where there will be requirements of either manufacturing or healthcare, where you're setting up guidelines for your workforce in dealing with AI. So there was a report that was done. It's the 2024 Work Trend Report, and it was a combination of Microsoft in conjunction with LinkedIn, seeing what employees are doing with respect to AI. And what they found was that 75% were bringing whatever they were using at home. So, for instance, if I was using Chat GPT at home, I started using it at work. So, there is a clamor for people to use AI at work, and those who either own companies or are leaders at companies should be paying attention to that and seeing what that can do for the organization, as well as having the guardrails in place to keep everyone safe from a cybersecurity standpoint as well. So, the other thing that they found was that a lot of the leaders did not want to hire people that weren't comfortable using AI. So, this is a tool to have in your tool belt. So, it used to be people would ask you about your work experience, which they still do, but this is now a new question that you may be asked. And seeing if you're able to utilize AI, and then that improves your value in the marketplace. So it's not that jobs are going away, but they look different. And this is a way of keeping you marketable as well as happy and getting through the day faster. The third thing that came out of this study was it's not generational. So it's not limited to my teenagers using this. So I remember thinking that, prior, and the pandemic did a lot to move things in this direction, being able to utilize our electronic tools. I was practicing 100% virtually for a few years prior to the pandemic. And there was some difficulty in adoption of electronic tools for patients that were a little bit older at the beginning. Then you had the pandemic, and our patients who were older, it became their lifeline for social connection. They were rapid adopters. And it seems like there's been a change in behavior, and now it really has a breakthrough across the generations for being able to utilize our electronic tools. So I remember probably 2 years after lockdown, where there was a large shift, and all of a sudden my elderly population was one of my most common patients that were on virtual visits, just because they liked it and they became very savvy about it and they saw the value. So it's not generational. This is for all workers and all of us to be able to eliminate those tasks, like taking out the laundry, taking out the garbage, parsing through that data in a much faster way than we can do. So that is our future. So this is a Shakespeare quote: "The past is prologue and the future is now." And this is another one of the AI generated images. I've started doing these regularly, and they're actually fun. I'm using Chat GPT as well as the Bing Copilot, especially since I was working on Microsoft and Edge after my behavioral change. And whenever I run, what I've done is I've got a mental trigger now. If I find that I'm struggling with either starting a task because it just seems onerous, or I'm in the middle of a task and I'm getting burdened, I pause and think, okay, if I bring in the AI, can it help me parse through some of this and get this done faster? And it has. So I hope you're able to take away some encouraging points from this. There are many more ways that AI is touching our field in sleep and respiratory medicine. This is just one example, but I hope this gave you a framework for how we're looking at AI to improve how we approach our patients going forward. Thank you.
Hello, Dr. Lance. How are you today?
Doing great. How are you?
I am wonderful. Thanks so much for joining us. Give me just a moment. I have an announcement for everybody watching out there, and then we'll jump into the Q&A session. So for those of you that didn't hear this in the prior Q&A, the presentations from today's session will be uploaded and available later today through the FeedLoop portal. If you missed a survey pop-up, it will appear this day. You can access it this afternoon, where it will appear after a brief 2-minute delay. Wonderful. Thank you. You can imagine how many questions we get. People are very excited to get their CEUs in, so I want to make sure they have no issues on the back end. But Dr. Lance, again, thank you for your time. Thank you for your presentation. Very informative. If you've been watching the forum so far today, I think we are on a pretty solid trend up to our keynote speaker about talking about advancements in technology in the healthcare field. So absolutely perfect topic for where we're going today. Appreciate it.
Always a pleasure to be part of this conference.
Wonderful. Well, we'll jump right into the Q&A session for you. So the first question that came in from the chat, you mentioned that motivation of therapy is a driving force in compliance. How do you find out what those motivations are? How do you leverage those?
This is something I work on with my fellows all the time. And part of it is learning motivational interviewing and knowing how to listen to patients. And it takes practice. And it is very common in this day and age to have such constraints on our time with patients to walk into each encounter with a set of expectations. And you've got to get this across with a patient in X amount of time. It's learning how to ask those open-ended questions and stopping to listen and letting what they're telling you about their experience or about what they're expecting guide where your conversation goes. And that is very difficult in this day and age. So it's pausing to take time and listening and putting some of our own agenda on the back burner.
I love it. Your answer actually goes right along with Patty, who was on just before you, talking about asking questions, touch points with patients, and just really having a dialogue to understand them, their setting, their need, their motivations, right, if you will.
Yes.
One thing to go off of that, right, you talked a little bit about identifying existing motivations, but I think everybody out there has been in a personal setting where somebody has asked them, oh, I have a CPAP device. I throw it on here. I throw it on there. I haven't used it in quite some time. What can clinicians do, or durable medical equipment companies do, to create motivations for patients to utilize their device?
Well, and each one of those patient encounters is going to be different. Part of it is asking open-ended upfront, tell me about your experience, why you went down this pathway in the first place, and why did you quit? And the third why is, why are you having this conversation with me now? What prompted this? And this could go in one of many directions. You may have someone who says, I just want to ignore this. My doc or my spouse is bugging me, and I'm here to say I came. And those people, you can say, bless you. When you're ready, come back. We're here for you. Or it might take you in a direction of, I didn't have support in this arena with my PAP, or I didn't think I could make some adjustments or changes. And then you have an opportunity to re-educate. Or it may go down another path completely where it's time to say, you know what, let's re-engage your provider. And we may need to talk about either alternative therapy or multimodality therapy for your treatment.
Wonderful. Thanks for going into that. Like I said, I'm sure there's a lot of people out there that have those interactions. And I always wonder, what can I say to the person that I'm interacting with to motivate them to utilize the therapy? So to your point, I think just these patient touch points are going to be a huge factor going forward now, especially with the different modes that we can communicate with them, the different mediums, right? Another question that came in through the chat for you is, what is your recommendation for patients that are still hesitant to trust AI monitoring, such as compliance tracking, downloading corresponding mobile apps, etc.?
Part of this is getting to know who you're partnering with and then looking at their studies. So part of one of the reasons my experience has been partnering and look at what Enso Data is doing is that they've got one of the longest track records. So they've been out there a long time. It's just, forgive me, I'm in a motion detection office at the moment. So they've been in this game a long time, but they've also done validation studies. And if you look at the breadth of where they're pulling their information from and how they're correlating and validating, that's where the trust comes into play. You're seeing those studies and how they have validated, and this deep wealth of information that they're validating their deep learning models against. So it's not just trying to validate what they're looking at against 8 patients or 10 patients. We're talking about thousands and thousands and tens of thousands of nights and events, and then running the statistical analysis to prove the validity.
Wonderful. Thanks for your elaboration on that answer. I know we got a lot of questions that came in for you, so appreciate you going through it in detail. Another question that came through the chat, and I think that one of your later slides may have prompted this, is I know one of the slides, I forgot the title of it, but AI is not taking your job. I believe was kind of the gist that you were going for in that slide. So a question came up, many scoring techs out there are concerned about the future of AI and the need for their role as a human doing that scoring. Is that a valid concern, or do you have any insight into where that might be going for people in that position?
Well, there are also a lot of guardrails in place, and this is going to be a bit of a moving target right now as we explore and utilize these platforms. There's still, regulation that there has to be oversight and overview, and so that's where your quality departments, if you will, or how your individual locations handle quality and overreading and overscoring. So it's just like if you're getting an automated or generated report based on your polysomnography. And do you know that, are you periodically going in and looking at how things are reviewed, going in and looking at the raw data and doing that quality work? And that's something that we'll have to do with AI.
Mm-hmm. Wonderful. Appreciate your answer on that. Another one, we got 5 minutes, just so you know, so we're going to try to squeeze in a couple here under the wire with you. But are the AI programs that you're speaking of, are they compliant for use with current HIPAA regulations?
So they have to go through a process so that they're FDA approved, and HIPAA compliant. So if they get FDA approval, that's what part of that is. So none of that really changes. So, and for instance, I'll use Enzo just because that's who I have experience with. They go through the same rigors that any other portion of the industry does in handling patient information and protected information. So the short answer to that is yes. The other part too is working with your organizations. I know my past hats, I was at Cleveland Clinic and University hospitals, and looking at what the requirements are for your security when you investigate new technologies or new devices, and looking at the quality standards that they have, and are they using single sign-on, and et cetera, to be able to access information.
Great. Thank you for that. Last question we had, really good question to end off the Q&A with. How does one know if the input to AI for sleep medicine is actual, trustworthy information to build upon for the final product? What is the perception of scrutiny for AI as an adjunct to sleep medicine that is present in the current system of sleep?
Wow, I'm going to have to try to remember the first part of that question.
I will repeat it for you as you
No,
need.
you don't
Trust
have
me.
to. It's okay. You don't have to. No, these are really wonderful questions. So this is where you go back to knowing what your source is and seeing if that is a source that, where did they train the model? So when you're looking at either machine learning or deep learning models or full AI, you look at, what populations were they looking at? How many patients were they looking at? How many nights of data were they looking at? And then did they do the effort of validating that work? And then, of course, our usual standardization with FDA approval and such. Does that answer that?
Only the person who asked, I think, can exactly tell if that answered it or not. But I do appreciate you elaborating on it. It was quite a question, quite a mouthful to come in at the end. But obviously, it shows that there's a lot of engagement going on with these presentations today. I think people are really looking for some detailed answers because of the information you all are providing. But thank you again, Dr. Lance, for your time today. As I always say, we appreciate everything you do for patients, for providers, just for the healthcare industry as a whole. Thank you so much for joining us today. We really appreciate the time.
Great. Thank you. Anytime.
Wonderful.
Have a good day.
Have a great day. Take care now.
Thanks.